Hi, my name is Dr. Lulu Zhao. I'm an obstetrician gynecologist at University Hospitals in Cleveland, and I'd like to spend a few minutes today talking to you about a topic that's near and dear to my heart. I'd like to start my talk out today with a cartoon. In the cartoon, the doctor is busy examining the patient, lost in his own world of thoughts, when the patient suddenly looks up and says, "Would you like to know why I came in here today?" The point is, sometimes we providers in medicine get a little bit engrossed in doing things the way that we're used to. We get focused on pathology, our impressions of what might be wrong, whether the patient is following our plan, and sometimes we forget that the patient knows their lives best. Today, I'd like to talk to you about a different approach to medical care, one that might work a little better. I'm a board-certified OBGYN who is also fellowship trained in women's mental health. I started my career working with postpartum depression and anxiety, but over the years, I've increasingly worked in the field of addiction as well. Did you know that according to the latest national survey, that 5% of American pregnancies are complicated by illicit drug use? To put that in perspective, 5% is more than the percentage of pregnancies complicated by placenta abruption or previa, type 1 diabetes, maternal congenital heart disease, twins, or even breech deliveries at term. 1% of American pregnancies are complicated by illicit opioid use. This translates to 22,000 mother-baby pairs each year. 22,000. More than all the U.S. congressmen who have ever served, all the currently employed workers in the DEA, and far more than the 1,300 physicians trained in addiction medicine in the United States. Here in Ohio, about 6,000 women of childbearing age have lost their lives to accidental overdose and suicide in the past decade. During pregnancy and the postpartum period alone, the rate of accidental overdose has increased tenfold between 2008 and 2019. Opioids were involved in 100% of those deaths. The typical victim, 27 years old, white, and outside of the global postpartum period of insurance coverage. What would these wives, daughters, sisters, and loved ones have told us if they could speak to us from the grave today? What could have saved their lives? Focus groups of pregnant and postpartum women with substance use disorders highlight some treatment needs that are outside of what we consider to be traditional medical care. Firstly, they desire to be treated respectfully by their care teams. A lot of these women have been told in one way or another by the world that they're human trash. And if you ever make them feel that same way, they will not meaningfully engage in care. They would like for you to advocate for them, to respect their boundaries, and to meet them where they're at. They also would like providers to be mindful of their constraints, like time or transportation. A lot of the women I work with are working. They have children or elderly family members to care for. And to ask them to commit to 20 hours of an intensive outpatient program, plus a prenatal visit, plus a separate ultrasound, plus a consult with the hepatologist for their hepatitis C, all at different locations, all within the same week, it's going to be setting some of those women up for failure. Women commonly note that they need to feel safe. That means that they need to know that you're not trying to catch them in a lie, or trying to take their kids away from them, or that you're not going to give up on them as soon as they make a mistake. And then finally, they would like their care, just like you would, to feel useful. So that means if they need assistance with employment accommodations or troubleshooting with other women in the same situation, or a medicine that they would like to be prescribed, they would like for you to be able to provide that for them. Knowing this background, and amidst a very serious opioid epidemic in Ohio, we launched the Moms Clinic for Perinatal Addiction at the Rainbow Center for Women and Children in September of 2018. Rainbow was uniquely positioned to house such a clinic. For one, we had a world-renowned Level 4 NICU that served as a referral center for opioid-exposed infants all over the region. Secondly, we already had extensive experience in integrating mental health care and OB care through years of collaboration between the departments of psychiatry and OBGYN, so it wasn't a big leap to add in addiction care as well. Most importantly, Rainbow was designed to address social determinants of health in addition to medical need. That meant that on site, we had a bus stop, a WIC office, a financial counselor, a child care center, legal aid, and all the other things that people need to have a healthy lifestyle. Our concept for the Moms Clinic was simple. Patients would receive care at one location on one day with one provider who could act as the quarterback for all their needs throughout preconception, pregnancy, and the first year postpartum. That's a picture of our beautiful center here. We never forced women into any particular plan, even if we thought that plan was the best for her. Set some goals, we'd say. And if you're not meeting those goals, would you be willing to reconsider? To maintain rapport and to create continuity, we made ourselves highly available. My dear nurse Emily spent countless hours on the phone, writing letters, sending emails, anything necessary to keep this chain of communication intact. We talked to a lot of patients and their families about buprenorphine. And let me just take this time to say a few words about buprenorphine. Buprenorphine is not a miracle drug. Just like insulin alone doesn't take away your obesity or your love for bread, buprenorphine alone cannot undo all the brain changes that have occurred due to decades of substance misuse. However, it is darn hard to get into recovery if you can't get out of bed because your withdrawal is too bad, or you can't get out of an abusive relationship because that individual provides you with drugs or the money to keep you housed, or you die from an overdose. Buprenorphine takes away some of the obvious barriers to recovery: withdrawal, reliance on bad characters to prevent withdrawal, and death. Did you know that use of buprenorphine reduces the risk of overdose death by 1/3 and the risk of all-cause mortality related to drug use by half? So we suggest buprenorphine to a lot of women because we consider it a life-saving medication. And that is the official stance of the American College of Obstetrician Gynecologists and the American Society for Addiction Medicine. We make it easy for women to get on buprenorphine. We admit them 24 hours a day, 7 days a week to our high-risk service for buprenorphine initiation. We don't make them wait awkwardly in the emergency room or on labor and delivery. We give them comfort meds as needed to soothe that transition from an illicit opioid onto an FDA-approved medication. After all, in the grand scheme of things, 3 days of polypharmacy under the watchful eyes of your medical team is far safer than a lifetime of continued opioid and fentanyl use. Once outpatient, we take care that the buprenorphine supply is not interrupted unless there are serious concerns about medication diversion, medication side effects, or failure to comply with federal rules regulating outpatient treatment. That means if a woman calls and says that she can't make her scheduled appointment because her daughter is sick and no one else can watch her, we give her a temporary refill until she can get to her next scheduled appointment. We believe buprenorphine to be a life-saving medication, which means you need to have a high threshold for taking it away. And then finally, we spend a lot of time talking to patients and their families about neonatal opioid withdrawal syndrome, or NOWS. Our mothers are good mothers, and like any good mother, It causes them pain to think that their treatment could cause any kind of discomfort or harm to their child. So we talk about the fact that 70% of women will relapse without medication unless they are extensively and intensively involved in behavioral therapy. And if you relapse, your child can still withdraw. We talk about how there is no obvious correlation between your buprenorphine dose, what trimester you use it, and whether or not your child develops NOWS or how severe the NOWS is. And we reassure women that if they're on buprenorphine and no other illicit substances, they can and should breastfeed because breastfeeding has been shown to decrease the risk of NOWS and the severity of NOWS. And of course, if the women are not interested, we don't force it. We just set a goal and we keep moving along. So does the UH Moms model work? Well, in a world where 30% of women with an opioid use disorder will have a preterm birth, 91% of our mothers delivered a healthy full-term neonate. In a state where 50% of the children in foster care are there because of parental substance use, 70% of our mothers can proudly call themselves legal guardians of their child upon hospital discharge. Meanwhile, no mothers have ever died from suicide or drug overdose in the history of the UH Moms program. It's a good start, but we have to keep moving forward. In the first half of 2020, Ohio overdose deaths increased by 30%. The COVID-19 pandemic unmasked many of the vulnerabilities that still exist in the U.S. healthcare system. It is a travesty that lack of insurance, lack of transportation, lack of medical centers in rural areas continues to kill Americans at a staggering rate. Black individuals have been especially hard hit by the opioid epidemic as fentanyl has made its way into the cocaine and meth supply chain. For the first time ever in Ohio, Black overdose deaths have surpassed white overdose deaths. We have to do better. We have to make institutional and policy-level commitment to invest in addiction care. It seems odd that I can prescribe Adderall, Xanax, Vicodin without a special waiver or prior authorization, yet I can't do the same thing for 7 days of life-saving buprenorphine. Doctors like me need some mechanism to protect the time it takes to connect, educate, and collaborate with key stakeholders in the community. I can never focus on treating addiction if the primary priority of the hospital is to make money, because I could see 5 routine OB-GYN patients in the amount of time it takes to see 1 MOMS patient. We need to think carefully about who should be taking care of these women. At a lot of places, it's automatically assumed that high-risk maternal fetal medicine specialists should take care of these women. Unfortunately, a lot of counties don't have access to maternal and fetal medicine specialists, and some of these specialists are not particularly trained to treat addiction. In my opinion, every graduating OB-GYN resident, midwife, and nurse practitioner should be trained in the basis of addiction care and should be buprenorphine waivered so they can prescribe this medication. Together, we can make a dent in this opioid epidemic. And then finally, we need to continue to listen to our women. Yes, my patients do need medication and psychotherapy, but they also need housing, cash assistance, support networks to get out of abusive or enabling relationships. Until healthcare systems are able to effectively partner to address these very real issues, we will continue to only reach a segment of the population who needs our help. Right now, only about 11% of individuals with a substance use disorder engage in treatment. We have to do better. I'll end my presentation today with a quote from the famed child psychologist John Bowlby that I've always loved. If a community values its children, it must cherish its parents. These women, they are worthy. I hope you hear them. Thank you.
Hello, my name is Andrew Herring. I'm an emergency physician in Oakland, California. I've also specialized in addiction medicine and pain medicine. And today, I'm here as one of the principal investigators of California Bridge at Public Health Institute's National Opioid Leadership Summit. The California Bridge has a very simple aim. We want every health system in the state of California to provide high-quality care for substance use disorders 24 hours a day, 7 days a week. Does that seem kind of like a simple ask? Like maybe lacking a little ambition? Let me tell you, that's not the case. In fact, that is one of the most ambitious and innovative goals currently in healthcare. And let me tell you why. Because to achieve this goal, it means shattering decades of misunderstanding, of discrimination, and exclusion for people struggling with use disorders. It means questioning the fundamental issues that prevent coordination of care in healthcare. When it comes to opioid use disorders, the siloing of care, the separation between the emergency department, between hospitalists, between clinics, between the public health departments and harm reduction community. All of those cracks in the system, those gaps, that's where people die, where opportunities are missed, where treatment is stopped. It's a tightrope that requires an all hands on deck approach. So what we're doing is focusing on 3 core pillars. The first is treatment. Again, this seems simple, but it's not. Simply providing FDA approved, evidence-based treatment, the kind of treatment recommended by the Surgeon General, the National Academy of Sciences, and virtually every professional society, which is low threshold buprenorphine or methadone to people who present in withdrawal, with opioid craving, or other signs of a disorder. Incredibly, in the face of more than 72,000 drug overdose deaths per year, that simple idea of providing evidence-based treatment in the emergency department is not happening. What we've learned is that physicians want to do this. Nurses want to do this. Physicians' assistants and nurse practitioners want to do this, but they weren't taught how. Medical schools didn't teach this to us. Neither did residencies. So we are embarked on a absolutely massive project of technical assistance and training so that every emergency department, every hospitalist department, every obstetrics department has a clinical champion who understands use disorders and has a federal drug enforcement agency waiver or an X waiver that enables them to use buprenorphine to treat opioid use disorder. And when they use it, when they initiate treatment, we're working to make sure that that individual always has somewhere to go. That every pharmacy in California will fill their prescription. That every community will have a clinic who will welcome them without restriction, without delay. Because we know treatment, evidence-based treatment, not moral judgment, not abstinence, is how we save lives. We're focusing on culture because ultimately, the most well-intentioned structures and workflows fail if the clinical culture does not truly empathize with the needs of people using drugs and truly believe that it's a priority of their professional and personal life to make sure that people struggling with use disorders get the care they need. We understand that human connection between clinicians and patients is crucial. It is trust. It is how we bridge the gap between what has come before, the war on drugs, excluding, discriminating against people using drugs in the hospital setting, being cast aside in a dehumanizing and discriminatory way. That was the standard of care. How do we get from there to a compassionate pragmatism that sees this as just another reality of being a human being, that substance use is an expected thing? Most of you listening to this use substances, whether it's coffee or nicotine or heroin or Norco. To use a substance is very, very human, and so is to struggle with it. We're making the treatment of use disorders a boring, everyday part of being a doctor or a nurse. Connection. We all know division, siloing, fragmentation in many ways defines the state of healthcare in the United States. We know that if we convince a physician in an emergency department to initiate buprenorphine, and we get them to really buy in and understand why it's the right thing to do, we supply them, we equip them, and they're able to do it. But that patient walks out the door, and the pharmacy won't fill the prescription, and the clinic won't see them for 3 weeks. That's not a solution. We've worked very hard to build both structural improvements so that each one of those touch points in the systems changes their intake structures so that they're able to accept warm handoffs immediately, without question, without eligibility screening, without denials. And we've paired that with a substance use navigator model. The navigator model means that their role is not simply to provide counseling to the patient. It's not they're not there to quote unquote fix the patient. They're there to fix the system. They're there to find the complex and challenging pathway through what is often a hostile environment in healthcare, so that that individual who has been smoking fentanyl or using heroin or oxycodone or whatever it is and decides that they are done, that they want help, that motivation, that person is able to get the treatment they want, and that they're able to realize the benefits of treatment. If they're experiencing homelessness, physical insecurity, they need those issues addressed as well, or they'll never be able to realize the benefits of the treatment. So a holistic model that begins with understanding the spoken, the unspoken needs of the community of people using and struggling with drugs is a core of our approach. Because ultimately, as physicians, we all made the oath to first do no harm. So the concept of harm reduction is fundamental to everything we do, which means meeting every patient where they're at. There is no test, there is no requirement, there is no expectation of a motivational or decision for recovery that we've created. It is for the patient to decide, and we are there to help them collaboratively move away from harm and towards wellness. So with that, I thank you for your attention and encourage you to learn more about the California Bridge and to think about how you, in your life, in your institution, can think about people struggling with substance use disorders as just any other person struggling with some kind of medical condition, and to think practically and to not worry about a lot of this older baggage around morality, accountability, all of these classic things. And just think about, how do we keep people safe? How do we get them to the next day without having to resort to the street to use drugs that we know are so dangerous? And if we can just bring that mindset, that compassionate pragmatism, harm reduction, into every aspect of the healthcare system, we will end the opioid epidemic. So I hope you'll join us. Thank you.